What I wanted to say is Dr. Bai is a pulmonary physician, and I think the context in which Dr. Bai talked about leg cramps was in the context of certain medications. So maybe I'll let you answer that.
Well, I'm not sure I can give you a good answer because, that's certainly not an area that I spend a lot of time treating.
You guys can stay.
The speaker. But, if leg cramps are a real problem for you, what I would suggest is make sure that you see a doctor, get your blood tested. Sometimes electrolytes like calcium, lack of calcium, too much of calcium or sodium can cause, potassium can cause leg cramps. So make sure that those things are in good shape. Sometimes drugs, as Dr. Bai mentioned, can worsen leg cramps. So make sure your doctors review your medications and eliminate those drugs that may cause leg cramps. And finally, there are specific treatments for leg cramps. If all of those things are good, then you may need some treatment. And there are medicines or drugs that you can use to relieve leg cramps. Yeah.
So one of the questions asked is, if our air is cleaner, why do we have the same rates of COPD, especially with our declining smoking rates?
Good question.
That's a very good question. That's a very good question. So what we do know is that smog worsens COPD. Whether it by itself can cause COPD is open to debate. But certainly if you have COPD and you're exposed to air pollution or smog, then your COPD will worsen. So there is actually some evidence to show that people in other parts of Canada have worse COPD than people living in Vancouver. So I think air does make a difference in terms of living with COPD. The overall rates of COPD are no different in Vancouver than in Montreal, where the smoking rates are higher. And it just speaks to the number of different risk factors that are involved in COPD genesis. It's not just one thing, it's a multitude of things. And we need to be mindful of that.
So, Don, do you think part of it's is part of it that people are living longer, and so when I was a resident, a lot of people were dropping dead in their 50s of heart attacks. They're not doing that now. So, is that part of the explanation for the rising prevalence?
I think so. One of the graphs I showed was that the risk of COPD increases as one ages. So, aging by itself is an important risk factor. But again, that alone doesn't explain all of it. The other thing that I think we should be mindful is that there's a tremendous lag time between the years that you smoked and the time that you're diagnosed with COPD. So a lot of people smoked a lot in the 60s and 70s and early 80s. They may not be smoking as much now, but that has caught up because it takes many years to develop a symptomatic COPD.
So the next question is somebody who's describing that they've been told their shortness of breath with exertion is from their atrial fibrillation, and they wanted you to comment on how could that be or what the mechanism might be. And apparently they have no COPD evident with 2 of those breathing tests while in hospital, and this person's not overweight, not a smoker, not a drinker, but does have some difficulty exercising because of this shortness of breath, attributed to atrial fibrillation, which is a heart rhythm disturbance.
So atrial fibrillation is a common problem. So when that happens, your heart's beating faster than it should during exertion, and so it's not actually contracting very efficiently. So one problem you can have is you can have actually a build-up in the lung of blood. It's not passing through the heart quickly enough, and that's called pulmonary congestion, and that presents a shortness of breath and cough. That's one explanation I can think of. Don, any other comments on that?
So in more general terms, COPD is one cause of shortness of breath. There are many other causes, one of which is atrial fibrillation. But there, infection can also cause shortness of breath, and having blood clots in your lungs, and so on. So there are many different causes of shortness of breath. The important thing is that when you are bothered by shortness of breath, it's important that you get tested for a variety of different things, including a breathing test, which unfortunately is underutilized in British Columbia and all across Canada. It's a simple test, and one needs to do that.
So the next question is an individual who states that they've been a shallow breather for most of their life and their upper body somewhat constrained, and wanted to know if you had any suggestions or tricks for training in abdominal breathing.
Okay, it's a good question. So physiotherapists and other interested health professionals do try and teach a technique for abdominal breathing using a hand-on approach, trying to get you to focus on moving the anterior abdominal wall out with your breathing and not breathing with your ribs and your neck muscles. So patients tell me they benefit from those techniques. There is also benefit from nasal inhalation and breathing slowly and deeply rather than quickly and shallowly. But beyond that, I think you're probably stuck with the fact that if you have small lung volumes or a poorly developed chest cage, there can be problems in terms for the rest of your life in terms of exercisability.
It also speaks to the importance of engaging or enrolling in a rehab program, because not everything can be cured by one intervention. At times, it has to be personalized. So what may work for your friend in terms of breathing exercises may not work for you because you're a different type of breather. Maybe you're a nose breather, or a mouth breather, or rapid shallow breather, whatever it is. So it's very important that a professional assess your breathing and determine what is the most optimal technique for you to reap the benefits.
A question about lung transplant. Is it an option for severe COPD? This case, someone's describing their parent is 62 years old. He's been a smoker for 50 years, but has quit for a year.
Okay, so a lot of patients with severe COPD have had lung transplants around the world, and even in Canada and BC. Now, lungs, unfortunately, are a limited resource for transplant. It's much easier to get a healthy donor kidney than a healthy donor lung for a variety of reasons. So we have relatively few lungs and a relatively lot of people that need them, like young folks with cystic fibrosis. So there is a little bit of debate about whether you will actually live longer with a lung transplant on average compared to the kind of management strategies we're talking about here. So if I had severe COPD, I have mild COPD, by the way, from 10 years of pipe smoking in my 20s, but I'm not sure I would have a lung transplant because, in fact, the 5-year survival after a lung transplant, even if you had COPD, is only about 60%. That's a side effect of the medicines needed to reduce rejection of the donated lungs or other factors. So, a lung transplant is a life-saving but tricky idea. Donald has some thoughts on this.
I agree with you completely. But having said that, lung transplantation for COPD is an option for certain individuals. So if you think that you would like to at least know more information about it, you should certainly see your doctor, who can refer you or your loved ones to a specialized clinic that deals with lung transplantation and can provide you with all the necessary information so that you can make an informed choice as to whether lung transplantation is the thing for you.
So do air purifiers help with regards to COPD? Air purifiers.
I think a lot of people have strong feelings about this. My feeling is it's not harmful, and it may be of benefit. So by all means, get an air purifier. I also encourage my patients to get a humidifier although Vancouver is not that dry, but it can get dry, especially in the winter. And dry, cool air can be quite bothersome in terms of breathing. So I encourage my patients to get a humidifier. The only proviso is that the humidifier has to be cleansed very well each and every week, because poor cleaning can result in mold buildup, and that's really devastating for the lungs. So it's very important that the humidifier be well cleansed. But humidifier and cleanser, I think, should be considered for many COPD patients.
Just to add to that, it's important to think about what sort of purifier you get, though. So you really want to get a HEPA filter, which has a good job of filtering out diesel particles and so on. There are things on the market there which are bogus, like these ozone generators. And a patient of mine actually got worse. She got 2 of them and was biking on a station bike right next to them, and she got ill. So you have to be very careful.
Is there an overlap between COPD and asthma?
So that's an obvious and excellent question. And in my severe asthma clinic, half the patients never have normal lung function. They would meet criteria for COPD. So they always have fixed limitation. That's because their airways are scarred from years of inflammation. So these entities do blur into each other. There's even something called the Dutch hypothesis, which is that says that you're born with a risk for asthma and COPD, and under the right circumstances, you have a very clear asthma kind of pattern. Other circumstances, you will not have much symptoms in childhood. You start smoking, then you'll get the same type of problem. So they do blend. We use similar medicines, and sometimes they work. Sometimes they don't. So they do merge.
Yeah, so there are clearly people with asthma. Asthma is a distinct entity compared to COPD. I mean, they're both distinct entities. So there are clearly people with asthma. There are clearly people with COPD. But there are also people who sort of sit in between. But in terms of treatment, it really doesn't matter. A lot of the treatments that we use for COPD can also be applied to asthma and vice versa. So in certain circumstances, although we put certain labels to it, the reality is that the management may be very similar between the two conditions.
So a question around severe chronic obstructive pulmonary disease. So from a medical point of view, one knows that you should stop smoking. But, you know, if you have severe COPD, does it really matter if they smoke 1 or 2 cigarettes a day at that point? It's a good audience. Good question.
It's a very good question. If you think mortality and hospitalization, all these things are important, it does matter whether you smoke 1 or 2 cigarettes or whether you smoke no cigarettes. So smoking cessation, as Dr. Bai mentioned, is the single most important intervention or therapy, if you like, for COPD patients who smoke. So falling off the bandwagon will, unfortunately, increase your risk of having a flare-up of your COPD and increase your chance of dying from COPD. So it's that serious.
I mean, there are actually studies that show that it's amazing what 1 cigarette can do in terms of systemic inflammation. It's incredible, really. One day we'll look back on this period of all of us smoking and think, well, why did they do that? You know.
So for the end stages of COPD, what's the main cause of death generally besides the shortness of breath?
That too is a very good question. It's not as straightforward as you might think. So, and people have done large studies looking at, you know, how people with COPD die and from what sort of end stage condition that they die from. To make a very complex story relatively simple, a third die because they can't breathe. They just lose their breath, a so-called respiratory insufficiency. A third actually die from heart disease. And it's probably because breathing very hard from COPD causes tremendous strain to your heart, and because of the inflammation that's associated with the COPD, adversely impacts on the heart performance. And a third actually die from cancer, particularly lung cancer. So, these are very important, what we consider comorbidities in COPD, heart disease and cancer. And so when your doctor looks after you with COPD, he or she needs to consider not just the lungs themselves, but other organs like the heart in order to make sure that your risk is mitigated to a certain extent for these end-stage complications.
So one individual is describing that there's no respiratory rehab in their community, and they have severe COPD, they're very short of breath, walking even 20 steps. So what can they do themselves to help themselves?
Right, so that has been identified as a problem, actually, lack of rehab facilities across Canada. And there is a federal initiative to try and address that. But, one of the good things is that you can, if you go on some of those websites, there are home-based programs that work almost as well, which is just get a stationary bike, in your bedroom or in your living room, and hop on that and pedal as hard as you can for 30, 40 minutes, 3 times a week. And the other days you're not doing that, you're doing balance strengthening, walking, as much as you can. Those things are certainly better than nothing. They're not as good as those swept-up programs, but they are better than nothing.
And there are many now local community-based programs that are popping up, and hopefully some of those will occur in your area. And as Dr. Bai mentioned, you can certainly access the website, Canadian Lung Association, BC Lung Association, and they will provide you with some information. Failing that, you can call our COPD clinic at St. Paul's Hospital and speak with the coordinator, who's Jane Burns, and she can provide you with all the necessary information about what you should be doing at home to enhance your exercise capacity. And as Dr. Bai mentioned, rehab program is not just about exercise, although exercise is a very important core. There are other ancillary issues surrounding rehab, and so these issues can be dealt with even over the phone by a trained COPD specialist.
So you said that air pollution does not cause COPD, just aggravates it. Can you clarify that, and has there been sufficient research on this point?
Well, air pollution, although Environment Canada measures it in our environment, is something very difficult to quantify in terms of personal exposure, because there's air quality outside, there's air quality indoors, and air quality indoors changes depending on the venue that you're in. It's maybe less at your home, maybe greater at your workplace, and vice versa. So for a personal for an individual, it's hard to quantify the extent of smog exposure or air pollution exposure. And so the research in this area has lagged behind, certainly, that of cigarette smoke, which is easy to quantify, or easier to quantify. So, it's not entirely clear whether air pollution by itself can cause COPD. There are certainly individuals who believe that that's the case. What we do know is when the air quality worsens, say in Vancouver or anywhere, that respiratory symptoms develop at a much higher rate than would be expected in the community. And it's probably because the smog that we inhale causes our airways to become more irritable, and they contract. And people with COPD, as I've shown, have smaller breathing tubes to begin with. So a little bit of contraction of those airways can cause tremendous amount of difficulties in terms of breathing. So that's one example of how air pollution can worsen COPD symptoms. And some of the particles in the air, forget about even the gases, but some of the particles can penetrate deeply into the lungs of COPD patients and cause tremendous amount of inflammation both in the lungs and in the blood. And that too will make individuals feel more short of breath and feel very, very tired.
So I can think of two studies that convinced me that air pollution alone can cause COPD. One is a study of Mexico City dwellers, females that cook on open fires. They've done big surveys of those women, and they have lifelong non-smokers, and a substantial proportion of them do have COPD in relation to the amount of cooking they've done. Another thing that interested me recently was a study of diesel locomotive drivers in the States, and even among the lifelong non-smokers, a significant proportion of those greater than other occupations have COPD. So I'm pretty convinced that on its own it can do it.
So where can you get expert direction for oxygen use for someone who's on it 24 hours a day and has very decreased exercise tolerance? And in this case, it's due to radiation pneumonitis.
So in British Columbia, we've centralized oxygen prescription and care. So we have a whole service that is run by the government and health departments. So if I somebody needs oxygen, I write a prescription to the central authority, and our respiratory therapist, which is a specialized professional, goes to the home and optimizes and educates the patient about the use of that oxygen. So they'll make sure you're getting a high enough flow rate to keep your oxygen above these critical levels, which we know that if it drops below 88%, your oxygen for substantial periods of time, you'll have some cognitive problems and you will have a shortened life. So we try and keep the flow rate up. We have limitations in how much oxygen you can actually give, but in general, the system works pretty well, I think, through the home oxygen service, which is centralized in both Vancouver Coastal and Fraser Health.
What is asthma, and how does it differ from COPD? Can you clarify that again?
So, classically, the classical asthmatic, his lung function can normalize completely with appropriate treatment. If you treat them fully, that'll never happen with COPD because you've got two lesions, you've got scarring of the small airways, and you've got emphysema. And we can't reverse either of those things. What we're trying to do is to prevent them worsening. The asthma, which purely involves the airways, there's no emphysema. The inflammation typically involves a different cell type, more eosinophils, and we can scare those away much more easily than we can in COPD. So we have a much better therapeutic effect with our medications, our anti-inflammatories particularly. So a lot of asthmatics have very prominent allergies, house dust mite, mold, cats, and that inhaled antigen is triggering inflammation in the lung and causing swelling of the lining, mucus production, which we can stop by removing the cat or taking medicines, anti-inflammatory medicines. So much more treatable than COPD and somewhat different triggers. Hopefully that's kind of an answer.
And the other thing is asthmatics tend to be much younger. I mean, you've seen asthmatic children, for example. You would almost never see a child with COPD. That's almost unheard of. So COPD generally occurs beyond the age of 40, whereas asthma can occur at any age. And as Dr. Bai mentioned, allergy is an important component to asthma, but not so in COPD. The leading risk factor, as I mentioned in COPD, is cigarette smoke. Now, for those who are allergic and smoke, it's sometimes very difficult to separate asthma from COPD. But there are now sophisticated ways where that we can use, or sophisticated technologies that we can use to make a distinction in most patients, but not all.
So should most people over the age of 40 ask for a baseline pulmonary function test, just like one would screen for bone mineral density after a certain age, or for women to do a breast exam or mammography? Is that common practice, or should it be people who have symptoms? Like, how do you guys think of that?
Well, that's an area of controversy, and we're really talking about screening. Does screening breathing test help in any material way? I suppose one argument is they do if it's a smoker. Maybe the numbers, as Dr. Bai showed, if you, for instance, a 40-year-old smoker comes and breathes into this machine, and the doctor tells him or her that you have a lung of a 90-year-old. Maybe that's an increased motivation for him or her to stop smoking. But in general, I'm not in support of screening breathing tests. I think it should be used judiciously for individuals who are symptomatic, who have symptoms, and or at high risk of developing COPD, or are about to undergo a major surgical procedure for which knowing about the COPD status would assist the surgeon or the clinician involved in better treating the individual pre- and post-operatively. So I'm not in favor of general screening, but selective screening of high-risk individuals.
I agree.
Is hyperbaric oxygen effective in treating any lung disease?
In general, no. Diving sickness, one or two very rare infections where we use hyperbaric oxygen to help in an attempt to try and help healing. But I'm not aware of any major use.
So air pollution is considered one of the problems for people with COPD, but what about perfume or cologne? Is it considered as bad as air pollution, or?
Not in my view. I think that those fumes are irritants, and you've got irritated airways already, and there are these nerve endings there that are prone to react to those fumes. So it causes cough and tightness and shortness of breath, but it's not the same as an inhaled particle of diesel fumes or something, which can really set off a systemic reaction. You can actually measure in your blood. Dr. Sin and his colleagues have measured changes in the blood after those diesel particles. You don't see that after fumes, I think, in cologne in general.
I agree with that.
Okay.
Does he have a question? I think that'll be the last question because it's 8:30, and probably everyone would like to have some refreshment. And
Okay.